We are back again with another talk on gynecology. This will be pelvic organ prolapse. And I neglected to talk about this much earlier when I was starting the gynecology lectures. I should have probably included this closer to the talks on urinary incontinence, particularly stress urinary incontinence, because these two have some association together. Nonetheless, we'll talk here about the pelvic organ prolapse, and that's more like pelvic organ prolapses because there's multiple different kinds. A 57-year-old G6P6006 presents to your clinic complaining of a sensation of pelvic heaviness over the past 6 months. For the past couple months, she's also had some occasional loss of urine while coughing or doing sit-ups at the gym. She denies hesitancy or urgency. Her past medical history includes 6 spontaneous vaginal deliveries and moderate obesity. Her BMI is 32.1, and she's also got type 2 diabetes. Her medications include atorvastatin, metformin, and a multivitamin. Physical examination is remarkable for a 3-centimeter bulge on the anterior vaginal wall, which descends with Valsalva. This is visualized on split speculum examination. All right, so let's take a look at what we see. And this is it. Okay, so this is a split speculum, this tool here. Unlike the bivalve speculum, where you've got sort of a tool on this side and a tool on the top, here you just have one on the bottom, and that allows you to visualize. If you stick it down this way, press down on the posterior wall, you can see the anterior wall, and then if you go back the other way, press up on the anterior wall, you can visualize the posterior wall. So it gives you, you can see both. Because with the bivalve speculum, when you go in, you're pushing up on the anterior wall and pushing down on the posterior wall. And that's good if you want to see the cervix. But if you want to see the anterior posterior wall, this type of this split speculum is best. Okay, so what do we see here? We see no cervix, and that's because we have a bulge on the anterior wall. Now, we don't really know just by looking at it if it's the anterior wall. You're going to have to go in and feel it, but this is indeed the anterior wall here, and this is the most common type of prolapse that you've got on the anterior wall is going to be, well, what sits right above the anterior wall of the vagina. It's going to be the bladder, and so this is most likely a cystocele, and this is consistent with her symptoms. The fact that she has stress urinary incontinence indicates that this is probably not only a cystocele, but a cystourethrocoele. There's going to be a little excess hypermotility of the urethra, and that's going to cause her to lose urine. And so you could go ahead after this and do urodynamic testing, and she is possibly a candidate for surgical correction. So this is what that looks like on a cartoon here. So you see the vagina, anterior wall, posterior wall. The posterior wall abuts the rectum. The anterior wall abuts the bladder. And so when you have a defect of the anterior wall, the bladder can then prolapse into the vagina. Okay, and that's where we get that. That's where we get that bulge from, and that bulge certainly will get bigger with urination, and then it can get smaller because the bladder size changes. Now, one of the problems that you run into with a cystocele is a feeling of incomplete emptying. Why is that? Well, the urine can come out. Okay, so think of it this way. If you have urine here, it's going to pool like that, and pool down like this, and then comes out. On the other hand, if you have this bulge here, it's easy to get the urine out from here, but then as you drain your bladder, it can collect in this area, and so you get this sensation of incomplete emptying because the bladder is still somewhat distended. Okay, so we will talk briefly about the epidemiology. We're going to spend a lot of time talking about anatomy here because the better you understand the anatomy, the more sense this is going to make. Okay, so I do think that focusing on the anatomy will be useful here. We'll talk about the pathophysiology and risk factors, and then the clinical presentation, how this presents. There's something called the pelvic organ prolapse quantification. You're never going to be tested on this. Even gynecologists don't really like this because it's very cumbersome, but it's worth knowing sort of what it is, even though you don't need to know it in detail. And then we'll talk about the treatment. So pelvic organ prolapse is an abnormal descent or a herniation of the pelvic organs from their normal anatomic position. And it affects millions of women worldwide, and it is responsible for at least 200,000 inpatient procedures per year in the United States. It is the third leading reason for elective hysterectomy in the U.S., and that is referring primarily here to uterine prolapse, in which case taking the uterus out would be curative. 11% of women in their lifetime will undergo a surgery for either prolapse or incontinence, and we really don't know how many cases occur per year because we don't really have a very good consistent definition of pelvic organ prolapse. The POPQ is the best we have, really. There are some questionnaires that can be useful, but for the most part we don't really have a great objective way of quantifying and defining this. Okay, so here's our anatomy. And I want to talk about this because this will help this make more sense to you when we determine how this happens. So I want to draw your attention to these ligaments, because when these ligaments become damaged, and the ligaments are one of the things that hold the uterus in place, also holds the bladder in place, but here we're primarily talking about the uterus. So these ligaments that surround the uterus hold the uterus in place, and if these ligaments become damaged, that raises your risk of developing uterine prolapse, where the uterus descends through the vagina and possibly even out the introitus and past the vulva. So, of course, we have the behind here, so behind the uterus and going posteriorly towards the sacrum, you have the uterosacral ligament, and this is also known as the rectouterine ligaments. They're paired, and they attach the posterior aspect of the uterus to the anterior sacrum, which is the bone that sits directly posterior to the uterus. Then we have the broad ligament. The broad ligament has three parts: the mesoovarium, the mesosalpinx, and the mesometrium. Ovarium, ovary, salpinx is the tubes, and then mesometrium is going to be the uterus. The mesometrium is the biggest part of the broad ligament. It's a double-layered parametrium, a very wide fold that extends from the uterus to the lateral walls of the to the ilium and the pubis, and so it attaches the uterus to the pelvis and the floor. So the medial parts of the pelvis and the floor. The broad ligament, as mentioned, consists of three different parts, but it's really the mesometrium that we're most concerned about. And then down along here, connecting to the cervix, is the cardinal ligament, and this is just the base of the broad ligament, the base of the mesometrium. It attaches the cervix to the lateral pelvic wall through its attachment to the obturator internus fascia. All right? So that is the ligaments that hold the uterus and the pelvic organs in place, and that is important when we're talking about uterine prolapse. Okay, so this is our normal anatomy here, and this is a sagittal view. So here, of course, we have the uterus and the vagina here, and then this is the hymen. It's the entrance to the vagina. And then here we have the bladder sitting anterior to the uterus and vagina, and then here we have the rectum sitting posterior, and this is the pubic symphysis. There's two parts, or two regions I want you to be familiar with. So anterior to the anterior wall, sitting between the bladder and the anterior wall of the vagina, is what's known as the space of Retzius. And then behind that, something you've probably heard of, is called the pouch of Douglas, or the cul-de-sac. And that's between the rectum and the posterior wall. And so these spaces will become sort of obliterated in the event that you have a prolapse. All right, so our anatomy, looking head on here. So we have the uterus and the cervix and the vagina. And when you have prolapse, this is going, the uterus and the cervix is going to descend through the vagina. Okay, so when we grade prolapses, we grade them based on where the prolapse is. Okay, so how far down distally it's going, how far relative to the hymen. Okay, so a grade 1 would be halfway between the cervix and the hymen. And this is the hymen down here. Grade 2 would be at the level of the hymen. Grade 3 is, this is what they say, halfway past the hymen. I'm guessing what they mean here is that if you feel the prolapse, it's half of it is inside, behind the hymen, and half of it is outside the hymen. And then grade 4 is maximal prolapse, meaning it's as far out as it can be. Okay. So there are various different kinds of prolapses. You may hear them referred to as cystocele, urethrocoele, rectocele, and pterocele. That's not the best way of defining these prolapses because you don't necessarily know what's behind the prolapse. So the better way to define it is based on where the prolapse is relative to the vagina rather than assuming it's a cystocele or assuming it's an enterocele. But for the most part, based on where the prolapse is, if it's anterior, posterior, apical, lateral, we get a pretty good idea what's probably behind it. Okay, so an anterior vaginal wall defect is going to be here. Okay, so this is the anterior wall. And this is associated with a cystocele, meaning just the bladder, a urethrocoele, meaning just the portion that's got the urethra, or both. And more commonly, it's going to be both. And that just depends on where it's at. If it's more proximal, more closer to the uterus, it's probably just going to be a cystocele. If it's much more distal, it might just be a urethrocoele. If it's somewhere in between, you can have both. Cystourethrocoele. Okay, so that's the anterior vaginal wall defect. A lateral vaginal wall defect is usually associated with a cystocele. So in this case, the bladder is prolapsing around the anterior wall and coming through the lateral wall. And this is also known as a paravaginal defect. And this is the most common type of pelvic organ prolapse, the most common defect. A posterior vaginal wall defect, so here we're, if you are palpating when she's in lithotomy position, you're palpating, it's going to be downward. That is most commonly associated with either a rectocele or an enterocele. So a rectocele is going to be more distal towards the introitus. An enterocele is going to be more proximal towards the uterus. And a rectocele is a prolapse of the rectum, and enterocele is a prolapse of the small bowel. And then an apical vaginal wall defect. So here we're talking about the wall around the cervix. This is going to be associated with either an enterocele or a uterine prolapse. Okay, and you'll know the difference because an enterocele, you'll generally you won't see a whole lot of cervix. You'll see a lot of apical wall, whereas a uterine prolapse, it's coming out all together. Okay, so the enterocele, the bulge is going to be somewhere along the apical wall, whereas with the uterine prolapse, the whole apical wall is going to be coming out at you. Okay, so here's some illustrations. So this is normal anatomy. You have your uterus up here, you have a nice long vagina, and then your introitus / hymen out here. You have your bladder sitting where it should. You have your rectum sitting where it should. Your small bowel up here. And this is perfect. Okay? So here, what is this? You're on B. You've got a nice circle here kind of telling you what it is. You see you don't have a whole lot of your anterior wall space here. Okay, so this is your cystocele. Okay, so you can see it's herniating down over the anterior wall. Okay, so how about this in C here? So here you see that the bladder is fine. You've got a good space in between the bladder and the anterior wall, but the posterior wall is compressed, and this is a rectocele. Okay, so this is the rectocele. And you would, if you were to palpate through here, if you palpated, you would feel a bulge on the posterior wall. And you'd be able to reduce this by using your speculum along the posterior side and compressing that down. But if you compress the anterior side, you would see the bulge. Okay, now this one is unique. So this is an enterocele, and where you're seeing this is, notice that you don't have a uterus. And one of the common ways that an enterocele can come out is through the apical wall. And so you're pushing the apical wall, and you're pushing it through the vault. And what's happening here, you don't have a uterus. This is because this person has had a hysterectomy. And when the hysterectomy is done, you're closing the vault. You're suturing the two portions together, and the uterus is taken out behind it. And that wall can become a little weaker, and then what's behind it is small bowel, and then that can herniate through. Okay, so this is an apical wall defect, and it's associated with a hysterectomy. Okay, but this is an enterocele through the apical wall. Remember, you can get an enterocele, though, through the posterior wall as well. It can come around and abut the posterior wall. Now, the uterine prolapse can be divided into severities. You don't really need to know this, but you may hear this thrown around. So depending on how far the uterus is prolapsing down the vagina, it's divided up into 3 degrees. So first degree is the most mild, and in this case the cervix is protruding below its normal level just on straining, on Valsalva. So if you look on speculum examination, use your bivalve speculum for this, and you look at the cervix, you will see that the cervix is protruding during Valsalva, but then goes back to its normal position when she releases. And that's a first degree prolapse, uterine prolapse. A second degree prolapse means that on straining, the cervix goes all the way down towards the vulva. So in that case, you wouldn't even need to use a speculum examination. You just separate the vulva, and when she strains, the cervix is coming all the way down. And then third degree is complete. So the whole uterus is outside the vulva, even if she doesn't strain. And it's going to be so far out that the wall of the vagina is actually going to be covering the uterus. So the uterus will be covered in vaginal epithelium, because you can imagine if you were to push right here and push that all the way out, the uterus itself would be covered with vaginal epithelium. This is also known as complete procedentia, or you'll hear it referred to as uterine procedentia. You may hear any uterine prolapse referred to as procedentia, but third degree is complete procedentia. Okay, so this would be the complete procedentia. Notice this is the vaginal epithelium here. This vaginal epithelium should be up around here. All right, so how does this happen? So normally we have good support on the pelvic floor, and the pelvic floor is provided, the support of the pelvic floor is provided by muscles, fascia, and ligaments. And particularly the muscle that provides our support of the pelvic floor is known as the levator ani. And that is a muscle that's actually composed of 3 different individual muscles. The iliococcygeal muscle, the pubococcygeus muscle, and the puborectalis muscle. And altogether they compose the levator ani. And you can get damage to the levator ani in various ways. Common way to get it is direct injury through childbirth. Another way that you can get it is a damage to the nerves, and that can be through stretching, and that can also happen through childbirth. And so damage to these muscles this muscle, which is composed of multiple muscles, can weaken the pelvic floor. Now, you might be thinking, well, why do women not get pelvic organ prolapse right after delivery? And the answer to that is, even though you get some damage to these muscles, what's probably going on is that, yeah, you get a little bit of damage, but you have other things. You have fascia and ligaments. And so that can provide you some support. But as you get older, the fascia and the ligaments get weaker. And so you're not relying on your muscle. Your muscle is weakened. You've got your fascia and ligaments providing most of the support. And as you get older, that gets weaker. And now you've got pelvic organ prolapse. So did I even put the risk factors on here? I don't even think I even put the risk factors on here. Okay. Oh, no, I did. Okay, we'll get to that. All right. So the big risk factor is multiparity, because you've got repeated damage to these support structures. But then also another risk factor is going to be age. The older you get, the more likely you're going to get pelvic organ prolapse. Okay. So there's different levels of vaginal support. So the vaginal support that holds the pelvic organs in place, mainly the uterus in place, is known as level 1 vaginal support. This is the cardinal ligament holding the cervix in place, and the uterosacral ligaments, and then also the broad ligament. And those hold the uterus and cervix in place. So a defect from this is going to lead to an apical prolapse, which is associated with uterine descent, uterine prolapse, and enterocele. The level 2 vaginal support is the paravaginal attachments contiguous with the cardinal and uterosacral complex. This provides your lateral support. So it holds the lateral part of the vaginal wall in place, and this is associated with a cystocele. This is the most common form of damage, and the most common defect is the paravaginal prolapse. So this is associated with cystocele. The bladder is just coming along down the side. Okay, and then level 3 is going to be the perineal body, the perineal musculature, which we already referred to, the connective tissue supporting the distal third of the vagina, and the defects here are going to be the anterior prolapse, which is associated with cystocele, urethrocoele, and the posterior prolapse, which is associated with a rectocele and an enterocele. Okay, so here's the risk factors. So multiparity is the big one. Remember, our patient is a G6P6, so she is at major risk. Can you imagine what's her name is? Michelle Duggar. She's got, 19 kids? I can imagine she's at major risk for pelvic organ prolapse. All right, other OB risk factors. So these are questionable, but there's been some studies have shown association with macrosomia. That would make sense, because if you're delivering a big baby, you're going to have more stretch, more damaged. Prolonged second stage, episiotomy, anal sphincter laceration, epidural anesthesia, forceps use, oxytocin stimulation, elective C-section. Those are all questionable. The big one is multiparity. Then probably the next big one is older age. The older you get, the weaker your connective tissue gets, and you can get prolapse. Connective tissue disease, here we're talking primarily about Marfan's and Ehlers-Danlos. I believe 1 in 3 patients with Marfan syndrome will get pelvic organ prolapse, and that goes up to 75% in Ehlers-Danlos. And that's just because their connective tissue is weaker. Race, Hispanics and whites have a higher rate of pelvic organ prolapse when compared to blacks and Asians. Don't know why that is. And then increased abdominal pressure. So this can be associated with obesity, Chronic constipation, chronic coughing, repeated heavy lifting. Obviously, the more abdominal pressure you have, the more pressure you're putting on those tendons and ligaments. And so that increases your risk as well. Okay, so what about symptoms? Far and away the most common symptoms are these bulges. The sensation of vaginal protrusion, pressure, heaviness. Problem is that this is subjective. So some women are more sensitive to this than others. But this is the most specific because these other things, urinary symptoms, bowel symptoms, they can come from all different kinds of things. But the bulge symptoms are more specific. There's fewer things in our differential if you have these bulge symptoms. These symptoms, sensations of protrusion, pressure, heaviness. Some of the other things that can cause that kind of subjective heaviness and pressure could include a rectal prolapse, which you can readily differentiate on physical examination, a cyst or a mass in the vulva or vagina, a pelvic mass, or another kind of hernia. Urinary symptoms. So this is going to be associated with the cystocele or cystourethrocoele, stress incontinence. So a lot of stress incontinence is associated with pelvic organ prolapse, but not always. But stress incontinence is associated with urethral hypermobility. Urgency and frequency, weak and prolonged stream, hesitancy, feeling of incomplete emptying. That's a big one because we know how that happens. You've got a portion of the bladder that can't empty because it's bulged down. And then difficulty with complete emptying. And sometimes what will happen is the woman will feel like she can't urinate all the way. She'll stick her finger into her vagina, push up on that bulge, and then the rest of the urine can come out. And that's very specific for a cystocele. Things that this can be differentiated from other things that can cause this is urethral sphincter incompetence, detrusor overactivity, which can give you symptoms of urgency, bladder outlet obstruction, which can give you a weak or prolonged stream, excessive fluid intake, which can give you stress incontinence, or can also give you a urge incontinence. UTI can give you a feeling of complete emptying. Interstitial cystitis can do that too. Bowel symptoms. So here we're talking about the rectocele. So a feeling of incomplete emptying on defecation because the stool is in that sort of herniated portion. Incontinence, and then digital evacuation. So it's very similar here. She's taking her fingers, putting it in her vagina, and pushing up that stool, and then she can evacuate it. And this is the most common bowel symptom with the posterior wall prolapse. And then sexual symptoms can be present as well. That's very obvious why that happens. So you've got this big bulge in your vagina, and then you have coitus, and you're pushing that around, and there's nerves around that, and that can be painful. So dyspareunia, decreased lubrication, probably decreased lubrication because there's some association with pelvic organ prolapse and with vaginal atrophy because both are associated with decreased estrogen. I didn't mention that earlier in pathophysiology, but a decreased estrogen will decrease the strength of those ligaments, and that's probably why it happens more as you get older. And so there's probably some, those two things are associated but not causative of one another. So you get older, you have decreased estrogen, and that can predispose you to pelvic organ prolapse and predispose you to decreased lubrication by virtue of having atrophic vaginal atrophy. Decreased sensation, and then decreased arousal or orgasm. So there's some sexual symptoms. Dyspareunia will be the big one. And then pain, that's very subjective. They can have back pain, genital pain, etc. So when you do your physical evaluation, you want to first start with a visual examination with and without Valsalva. You want to see if there's any protrusion. Generally, a woman will tell you right away, I got something coming out of my vagina and I don't know what it is. But you want to look, and then you want to have her bear down to see if there's any visually obvious protrusion. Then you can do your bimanual exam, and then you want to have her bear down there, and you want to feel the anterior wall, the posterior wall, and then up against the apex. And you want to feel if there's any bulging going on. You might feel it just on regular, if she's not doing Valsalva, or you might only feel it if she's doing Valsalva. Then you can use your bivalve speculum. Your bivalve speculum will help you identify the cervix and the apical wall, and then your split speculum will help you examine your anterior and posterior wall. And again, whenever you're doing these, you want to have her bear down, because so you look at it, you'll look at it, and then you'll have her bear down as well to see if it's worsened or it's present with increased pressure. Some of the abnormal findings. So if you do see something abnormal, what you want to note, of course, is the anatomic position of the prolapse portion. If it's on the anterior wall, posterior wall, if it's apical wall. Then you want to note the presence or absence of rugae. We're going to look at some pictures because that can give you an idea of where it's at. And that can be difficult because it might look like it's an anterior wall defect, but it might be something else. So rugae present is consistent with a lateral or paravaginal defect. And remember, this is the most common defect. So if there are rugae present, even though it might look like an anterior wall defect, it might indeed be a lateral defect. And then you want to note the approximate distance or extent of the prolapse in relation to the hymen, as we already said. Okay, so here's some prolapses. So you can see here, just looking at it, it's very difficult to tell. You'd want to get in and feel it because it's hard to tell just looking at it, what's this up here, what's this down here. But you can see here with this MRI that was done, you can see that this is a herniation of the bladder, and this is an anterior wall defect. Now note here, what's going on is that you have an apical wall defect, you have an enterocele, and you have no rugae here. So this is an apical wall midline defect. And then here, what do you have? This is a rectocele. So the rectocele tends to be more on the distal side of the posterior wall. Remember, you can get, with the posterior wall defects, you can also have an enterocele, but that tends to be further back if you were to feel it. But the rectocele tends to be further up, more distal, towards the introitus. Okay, so this is a posterior wall defect and it's a rectocele. So these are some of the areas where you can have defects. This is looking down over the bladder. And so these midline defects, you will not see rugae. Any of these can cause you to have a cystocele. So the distal, and okay, so this is, just to point out, this is anterior up here, posterior back here is your sacrum, your symphysis pubis. So the distal, the central, and the transverse here are midline defects. Right? The lateral or paravaginal are not. And it's going to be the lateral paravaginal, which is the most common, and it's the one that's going to give you rugae when you look. Okay, so all these cause cystocele, but it's only this one that's going to give you rugae. All right. So, okay, so here's a great example. So if you look at this, it might look like it's apical, but if you get in and feel around, you would notice this is lateral. Just, you got to get in and kind of feel around it. But looking at the fact that you have these rugae, and there's rugae in the vagina, but they serve the purpose of extending the vagina during childbirth so it can elongate. But the rugae present on the bulge is consistent with a lateral defect. Now this is also a cystocele. This is the one we saw earlier, but this is associated with a midline defect because there's no rugae present, no visible rugae present. Okay. So this could be distal or central or transverse defect. And it's the transverse defects that are most associated with urethral hypermobility. Okay, what is this? What's this up here? This is a cervix. And this whole thing is a uterus. So this is uterine prolapse, and this is in fact a third degree or complete procedentia. It's all the way outside the the vulva. This is the POP-Q, so do not memorize this. But gynecologists, some of them, not all of them, because some even find this very cumbersome. But basically what it is they measure everything relative to the hymen and also to the external urethral sphincter, the meatus here. And there's a few points that are fixed, and then the rest of them can move around, and they measure them all. So AA is always 3 centimeters from their meatus, and AP is 3 centimeters in, and then they measure where the cervix is, where the Douglas pouch is, and don't memorize this. But this is the best way we have of quantifying where everything's at and how bad it is. Okay, what do we do for treatment? So we can approach this non-surgical or surgical. And how we go about treating this is really going to depend on how symptomatic the woman is, whether she wants treatment, how severe her symptoms are. And for women who are asymptomatic or mildly symptomatic, we can just do expectant management. If the woman, though, has severe significant symptoms or bothersome symptoms, or she wants treatment, then we can go ahead and consider treatment. And what we want to consider when doing treatment are the type of symptoms she's having, how severe they are, her age. If she's younger, then we can maybe look at surgical therapy. But usually we start with non-surgical therapy. We also want to know if there's medical comorbidities that might preclude surgery or make us think that surgery might not be the best step right away. If there's desire for future sex function, we'll talk about that in a little bit. Desire for future fertility, and then risk of recurrence. And that can determine what kind of surgery you do or whether or not we do it. Generally, we start out with non-surgical management. And far and away, the first line of management for pelvic organ prolapse is going to be the pessary. And a pessary is a support, like a support structure that you put in, and it helps give you some added support for the pelvic wall. So the pessary is the first line. There's all sorts of different kinds of pessaries. One of the more common ones you'll see is this ring pessary. So there's 2 different kinds of pessaries. There's the support pessary, which uses a spring mechanism. This ring pessary is the most common, but this is also a support pessary. This one gives you a little bit, I can't remember what it's called. The names can be confusing, but a lot of them are named after people, like all those surgical tools. This one gives you a little bit, it's got a little bucket kind of on it, a little area to collect stuff, and this can help you collect urine or can help you collect secretions or whatever. But this one is the ring pessary, and this is just inserted up close to the cervix, and it gives you some support there. When you put this up, it'll rest on the posterior fornix and against towards the anterior side, the posterior aspect of the symphysis pubis. The other types of pessaries are these ones here with the, you can't really see it, but they give you some suction. This one here is a cube pessary, and this here is a donut pessary, and then this one here is called a gel horn pessary. And these are collectively known as space-filling pessaries. They work with a suction mechanism, particularly here with the cube pessary. They can also, when you put them in, they create a diameter that's larger than the genital hiatus, and that sort of puts pressure on all those pelvic organs to kind of keep them out of the way, keep them from prolapsing. And then some of them work with both mechanisms, and that would be like this gel horn pessary here. Okay, so as they go in, so this ring pessary here, this one is really good for the uterine prolapse, and you just kind of put it in and it goes around the cervix here. This gel horn prolapse also kind of works the same way, okay, but it also will give you some support along the wall too. And then this works with suction. Okay, so with the pessaries, first, a good thing to do is to evaluate for vaginal atrophy before you place it. There's 2 reasons. First of all, vaginal atrophy can make your pelvic organ prolapse worse. Another reason why you want to do this is because you're putting the pessary in, and if you have vaginal atrophy, the tissue is going to be kind of weak, and you can hurt the tissue. That way you can get kind of ulceration and stuff like that. So if there is any vaginal atrophy, you want to treat that either before or during the pessary use. And women who are candidates for estrogen therapy can get that, and you can just give them cream, 1 gram of conjugated estrogen, also known as Premarin cream, and then they'll put that in their vagina every night for 2 weeks, and then twice a week thereafter. And that will help prevent some of the irritative symptoms from these pessaries. Before you place it, and you'll place it in the clinic, you want to make sure she voids her bladder, and then you want to use the biggest pessary you can that's comfortable for her. Because the bigger it is, the more support you'll have. And you'll want to have her get up, walk around, try sitting, moving around, have her try urinating, coughing, to make sure it's comfortable. And then you'll want to teach her how to remove and insert it, because she's going to need to do that at home. And she should remove the pessary, preferably every night would be great, but even every week would be okay. Even every few months is all right. We really don't want that. If she really just doesn't know how to do it, can't learn it, she can come into the office and have it removed and cleaned and reinserted. The problem really with not removing it frequently enough is you can gather these secretions and odor, and it gets kind of nasty. So ideally she removes it frequently and replaces it, but if she can't, that's okay. The complications from pessaries are primarily ulcers from irritation, and then the odor from the secretions. And then Kegel exercises are another way of strengthening those muscles. Studies have shown that they're not necessarily really effective, but it's really easy to do and to learn how to do it, and it can't hurt. Okay, so pessaries, #1 treatment, non-surgically, and then the Kegel exercises. Surgical management. So if the pessaries are just not doing it for her, she's still having symptoms, we can look at surgery. There's 2 ways to approach surgery: obliterative and reconstructive. Obliterative is primarily reserved for really old women that just don't care to have sex anymore, or women who are medically compromised and are not going to be having sex. That's the big question. With the obliterative management, primarily here we're talking about colpoclesis, you're basically sewing the vagina together. So she's not even going to have a vagina anymore. And that works really great for pelvic prolapse. The problem is she's not going to be able to have sex because she doesn't have a vagina. So you really have to ask that. If she doesn't want to have sex anymore, then you can do obliterative therapy. It's very easy. You sew the vagina together and you're done. And that works really well. But otherwise, you're going to need to do reconstructive surgery. And here, with the reconstructive surgery, there's a ton of different surgeries. It really just depends on where the defect is, whether it's anterior wall, posterior wall, apical, etc. But what we're doing here is we're attempting to restore normal pelvic anatomy. Like I said, there's a variety of surgeries. There's also a variety of approaches. You can do it abdominally. You can do it. Vaginally. You can go all sorts of different ways. Vaginally is the most common, and the ways you can reinforce this is with sutures, with meshes, with biomaterial. So all different kinds of surgeries and approaches. Different surgeries can include ligament fixation or suspension, particularly for apical support. You can also, and it can be useful, especially if she's having symptoms, to do a urodynamic testing and see if there's any kind of incontinence issues. And then when you do the reconstruction, you can also do a concurrent anti-incontinence surgery. Another reason why that can be useful is when you're doing, if you do like an anterior wall repair, you can get some, you can cause her to have stress incontinence. If she didn't have it before, it can get worse. So it can be useful to go in and do anti-incontinence procedures in addition to that. So that's one thing that you may want to consider before surgery, to do urodynamic testing, see if she has any stress incontinence, even if it's asymptomatic. And then if she does, then you can do the anti-incontinence surgery along with your reconstructive surgery. Okay, so that's all I have for you here. Lots of information, but you should know everything about pelvic prolapse that you want to know if you are working in primary care or if you're going to be taking tests. I will see you next time.